cries, feel the pain, heal the suffering, no woe shall remain. Believe in cruelty kind, the road ahead may wind. Must not your promise waver, comforting the weary traveler, comforting the weary traveler.
Hello, and welcome to Palliversation, Conversations in Palliative Care. As the title suggests, we will be discussing different topics in palliative care. These videos are being created with the sentiment that the medical communities in the different parts of the world are bonded by the same moral duty of treating suffering. They all strive for the same scientific achievements. They all work diligently to attain clinical excellence. This makes us one medical nation, notwithstanding the geographical boundaries. The ups and downs, the successes and failures ought to be shared with each other so that we don't make the same mistakes, don't spend time in reinventing the wheel, and continue to grow together. Efforts have been made to present this information artistically. Hope you enjoy watching these videos and find them thought-provoking at the same time.
Palliversation, conversations in palliative care. What is palliative care? Palliative, this seems to be a fashionable word these days, but very few people, even if they are in medical field, have a clear idea as to what palliative care is. So is palliative care a new fleeting fashion? No, not at all. This way of thinking has aspired to become a part of the psyche of the medical profession. Yes, it's a new paradigm. As we all know, at one point in time, medicine was practiced in a paternalistic way with very limited resources. Then the experimental medical science took over, and medical armamentarium, if you will, got well equipped, literally got filled with many new drugs, including antibiotics, anti-cancer drugs, anti-cardiac diseases drugs, so on and so forth, raising the expectations of the public, imparting medical science almost a magical quality. At the same time, medical practice got inundated by multiple tests, blood tests, radiological tests, invasive tests, this test and that test. And before the doctors knew it, the test tubes and the x-rays became more important than the patients. Doctors nowadays feel obliged to order a test instead of relying on their clinical judgment. This made the doctor-patient relationship quite complicated than ever before. But the practice of medicine is introvert and dynamic. It keeps on evolving. It's a philosophical evolution, a necessary internal change, keeping in pace with the advances in medical science. This change is going to cloak the medical care in a very positive way. It is going to steer the medical system towards the patient. A patient-centered, symptom-focused system is called palliative care. But this is only an explanation, not the real definition. So let us ask a person who is well immersed in palliative care. This esteemed person is Padma Shri Dr. Raj Gopal from Kerala, India. He's the founder of a great organization, Pallium India, that is dedicated to the palliative care and is recognized internationally. Dr. Raj Gopal was nominated for the 2018 Nobel Peace Prize. So let us talk to the guru of palliative care. Welcome, Dr. Rajgopal, to Palliversation. It's an honor and privilege to have you here with us today. I have a very basic question for you. What is the meaning of palliative care?
To answer your question on sentence, palliative care is prevention and management of serious health-related suffering. Serious health-related suffering has to be alleviated. We doctors are taught to diagnose and cure diseases. We were not taught how to identify elements of suffering and relieve it. We grew up as doctors without thinking that we have any responsibility to intervene in emotional or social issues causing suffering. So palliative care is prevention and management of serious health-related suffering, which then has to start when the suffering starts.
Exactly.
Which can be even before the diagnosis. So this is the message. Unfortunately, globally, palliative care started by caring for the dying. That's what Dame Cicely Saunders did in St. Christopher's Hospice.
Yes.
So that association has stuck. Yes, you are quite right. If I say that I practice palliative care, oh, you do mercy killing, could well be the reaction. Maybe not in Kerala where it's more known, but certainly in most of the country. So we will have to keep on highlighting this point that this is about suffering. This is about needless suffering, and that needs to be treated.
Thank you, Dr. Rajgopal, for talking to us today regarding this important topic. Now, if you are going to appear for a board exam in internal medicine or family medicine, or you're already out there practicing medicine, you should have a pretty clear idea about what palliative care is. You should know, especially while practicing medicine, that which patient qualify for palliative care and who does not qualify at all. Okay, so the definition of palliative care by the National Consensus Project for Quality Palliative Care is an interdisciplinary service provided at any stage of a serious illness. I underline a serious illness. What is a serious illness? Is a simple pneumonia that is being treated as an outpatient with oral antibiotics, or even if a patient needs hospitalization for a couple of days for IV antibiotics, is it a serious condition? A heart attack, which was caught in time and promptly treated with interventions, or a stroke that has left some minor deficits, but patient is able to carry on with his life normally, or a cancer which was diagnosed in its early stage and has been treated adequately. All these conditions are significant in patient's life, but not serious enough to qualify for palliative care. By definition, a serious illness is an illness that carries a risk of mortality and either negatively impacts a person's daily life or the quality of life, or excessively strains the caregivers. What are the serious illnesses? Here is the list of serious illnesses. The first category is that of neurological diseases. And one has to remember this because whenever the word palliative care is said, a person starts thinking about cancer patients unknowingly. But a big chunk of the serious illnesses category is occupied by neurological illnesses like amyotrophic lateral sclerosis, Huntington's disease, multiple sclerosis, strokes, Parkinson's disease, etc. The other diseases which also fall into these categories are coming from organ failures, such as chronic obstructive pulmonary diseases, congestive heart failure, end-stage liver disease of any etiology, end-stage kidney disease of any etiology. Metastatic cancers, of course, AIDS due to HIV infection, and sickle cell anemia. And any other patient who has a prolonged, complicated illness, difficult to manage by a single doctor, they may be put into this basket as well at the discretion of the primary care physician. What is an interdisciplinary team? That is the other important word in the definition of palliative care. The interdisciplinary team consists of a basic team of a physician, a nurse, and a social worker. Hopefully, they're all trained in palliative care. And the ancillary services, such as a certified nutritionist, a physical therapist, occupational therapist, pharmacist, wound care nurse, and a chaplain, and most importantly, a volunteer. And a team of volunteers can do wonders to patient care. And if you're going to start your own palliative care, please be aware of it. Now, how do all these providers help patient improve the quality of life? They improve it by anticipating, preventing, and managing the complications of any chronic illness. So how do they anticipate the problems? So suppose a patient has amyotrophic lateral sclerosis, ALS. These patients are destined to get dysphagia, that means difficulty swallowing, and they suffer from poor nutrition. So to be ahead in the game, these patients should have a feeding tube placed. Eventually, they also have respiratory difficulties, so they start using CPAP, BiPAP at night, so on and so forth. So this is anticipation of medical complications. And for this, the provider should know the diagnosis, the correct diagnosis, and the trajectory of the illness. In ALS, as we all know, the trajectory is just a downward slope. Preventing the medical issues or preventing the complications. So how do we do that? So suppose a patient has hemiplegia, a patient is at high risk for falling. We look at the medication list, take out the medications which may increase the fall risk, make sure patient has a walker, the night lamp is on. Little things, but they make a big difference in patient's life. So preventing complications. How do we manage the complications? We are good at it. We are the medical provider. So we manage secretion, shortness of breath, pain, which is basically the symptom management, and depression. Do not forget that dimension in the palliative care. Now, the palliative care team addresses the whole person, a person who includes multiple dimensions such as physical, psychological, social, and spiritual. Let us look at a real life scenario so that we can apply this knowledge there. A 70-year-old man diagnosed with metastatic prostate cancer has severe back pain. He comes to your clinic due to severe back pain from bone mets, has nocturia, he's getting up at night 6 to 8 times, not getting enough sleep. He has chemotherapy-induced peripheral neuropathy because he got cisplatin for chemotherapy. He's almost chair-bound, is trying to ambulate with his walker somehow and can go to the bathroom, and that's all he can do, and he feels very tired. He lives at home with his wife, who is his sole caregiver, and he's religious, but he cannot go to the place of worship because of all these issues. And his wife feels guilty, she's very tired. Patient is losing weight, and in general, there is unhappiness in that household. So how is the palliative care team going to help this couple? The first and the foremost duty of a palliative care physician is the symptom control, symptom management. So the pain is the main issue, so let us start there. Acetaminophen and ibuprofen, which are the first line of pain management in the ladder of analgesics, they may not work and they may not be given on a long-term basis. So what is most helpful in cancer pain are the opiates, the opioid medication, morphine-like medications. So let us start with the lowest dose of oxycodone, 5 milligram every 6 hours as needed, monitor the patient for pain control and increase the dose as needed. Secondly, he also has pain from neuropathy. So add gabapentin for that, again at the lowest possible dose. He does have nocturia, which is compromising the quality of his life. So are we going to add oxybutynin? Because that may increase the risk of falling. So here, we need to make some compromises. And if we start him on a low dose oxybutynin, we need to educate the family that this can increase the risk of falling. We may get a palliative pharmacist involved in his care to look at the rest of the medications, so on and so forth. So that's symptom management. Secondly, and this is what the palliative care physicians do other than symptom management: communication, communication, and communication. So make sure the patient himself or herself is aware of the diagnosis and the prognosis. So goals of care need to be discussed, and the important issue is that of advance directives and medical power of attorney. This paperwork must be done at the earliest. The family caregiver support, as I said, respite care. If you give respite care to the patient's family, your doctor-patient relationship will reach a new good level, and it will be very rewarding. The nutrition is always a big issue in any chronic illness, so make sure you have a certified nutritionist on board, and she or he helps the patient figure out what kind of diet they can have within the limits of their cultural cuisine. The other things are very important as well, that getting a right to dialysis, or getting patient to his worship list, and as in this patient's case. And the last but not the least one is the reconciliation of medications. Patients' primary care physicians, other physicians, the pharmacist may do it, but do not rely on others. Do it yourself. If you are the palliative care doctor, it is your duty to look at the medication list, weed out the medications which are not needed at all, and prevent drug interactions. So you will do a big favor to your patient by doing the reconciliation of medications. So, as you must have understood by now, it takes a village to practice palliative care. So, create one. Hope you find this episode of Palliversation thought-provoking and helpful. Please join us again. Thank you for your time and attention. This is Bhagyashri Barlinge from Phoenix, Arizona. Have a nice day.